Most of us have no problem getting enough nourishment by mouth to satisfy our body's needs. But throughout the country, there are thousands of patients who don't eat, won't eat, shouldn't eat, or can't eat enough to maintain body functions. For these people, we must find different ways of providing essential nourishment. If there are no underlying gastrointestinal problems, gastrointestinal tube feeding is the chosen method of providing essential nourishment. However, for those patients with limited gastrointestinal function, total parenteral nutrition, TPN, can effectively and efficiently provide life-saving nutrients.
This program, part 1 of a 2-part series on the management of TPN, will discuss the uses of hyperalimentation, explore the choice of venous access devices, present an overview of the various solutions used for TPN, including their handling and storage, and demonstrate how to administer TPN solutions. Part 2 will discuss how to monitor the patient's status and how to prevent, recognize, and treat possible complications. Total parenteral nutrition is indicated for those patients with 2 or more of the following conditions: little or no oral intake for 7 days or more, a recent weight loss of 10% and/or a continuous loss of weight despite adequate oral intake, serum albumin levels less than 3.5 grams per 100 milliliters, poor tolerance to long-term tube feeding, or chronic vomiting or diarrhea. Solutions used for TPN need to be highly concentrated. If such solutions were to be administered through peripheral lines, they could damage the veins and lead to venous thrombosis. By infusing the TPN solution into the central venous circulation by way of the superior vena cava, the solution is rapidly diluted and quickly dispersed, thus preventing damage to vessel walls. In order to provide repeated access to the central venous circulation, an indwelling venous catheter is inserted into the superior vena cava, usually through the subclavian vein. 2 types of venous access devices are commonly used: the multilumen catheter and the implantable catheter. The multilumen catheter, which is tunneled through the chest wall, has 4 to 5 inches of catheter protruding from the exit site. This catheter has a Dacron cuff, which stabilizes the catheter and minimizes the risk of ascending infection. Daily dressing changes are required when the catheter is first inserted. The frequency of dressing changes decreases to every other day as healing progresses. After 2 to 3 weeks, the exit wound is healed and dressing becomes a matter of choice. The implantable catheter terminates in a stainless steel or plastic port that is surgically implanted in a subcutaneous pocket in the chest wall. A post-surgical dressing is needed until the wound heals, but thereafter there is no external evidence of the catheter, except for a slight protrusion of the chest wall. Although each catheter has advantages and disadvantages, safety and type of treatment generally dictate the type of catheter used. For the patient who requires intermittent injections, an implantable port is preferred. For the patient who requires repeated venous access for blood sampling, intensive chemotherapy, and/or TPN, the long-term multilumen catheter is indicated. Other considerations include cost, appearance, convenience of use, activity limitations, and patient's preference. A new catheter, the Groshong catheter, has been introduced in both implantable and multilumen versions. This catheter has a one-way valve at its tip that prevents backflow, thereby reducing the risk of air embolism and bleedback. The Groshong catheter also eliminates the need for heparin to maintain catheter patency, requiring only flushing with normal saline once a week when not in use, as opposed to the daily flushing of the multilumen catheter. Since the care and maintenance of the central venous catheter and catheter site varies with the type of catheter used, it is essential that the nurse be familiar with the protocols used for each. To review, type of therapy, safety factors, and patient's preference generally determine which of two venous access devices is used for TPN. Solutions administered in total parenteral nutrition are tailored to the specific needs of each patient, but all regimens have some things in common. Concentrated dextrose solution is the primary calorie source in TPN solutions. Recall that 1 gram of dextrose yields 4 kilocalories. Therefore, 1,000 milliliters of 10% dextrose would yield 400 kilocalories. Since most patients require 2,500 to 3,000 calories per day, it is obvious that the volume of fluids must be greatly increased, the concentration of dextrose must be increased, or additional calories must be supplied from another source in order to meet daily requirements. Most patients require 2 to 3 liters of fluid per day in order to meet the metabolic demands of the body, although this can be as high as 6 or more liters if the patient is losing copious amounts of fluid. Administration of an excessive amount of fluid can result in both an overhydration of the cells and an increase in extracellular fluid, so the patient usually should not receive more than 2 to 3 liters of fluid per day with TPN. Since 3 liters of 10% dextrose solution would yield only 1,200 calories, increasing the volume of liquids cannot be the answer to providing extra calories. Can we increase the concentration of dextrose to provide more calories? Patients have been shown to tolerate up to 70% dextrose solution if exogenous insulin is added to the infusion. However, such high concentrations of dextrose do present a problem to the delicate chemical balance of the body and may result in hyperosmolality, volume depletion, metabolic acidosis, and hyperglycemic non-ketotic coma. The optimum percentage of dextrose for a patient on TPN is highly individualized and is formulated by the nutritional support team, who closely monitor the patient's reaction to the solution until the right mix is found. But what about other sources of calories? Provision of protein in the form of amino acids is required to maintain proper nitrogen balance, maintain lean body mass, and promote tissue synthesis. For the patient receiving amino acids in TPN, the daily requirement is 1 to 2 grams per kilogram of body weight, or an average of 70 to 140 grams of amino acids. At 4 kilocalories per gram, this would add only 280 to 660 kilocalories. Then what role do lipids play in TPN? At 9 kilocalories per gram, lipids are a useful energy source in low volume. Moreover, lipids are required to provide essential fatty acids for the body. Since essential fatty acid deficiency may be prevented by the administration of 500 milliliters of 10% lipids twice weekly, many institutions use this method in TPN, thereby adding 550 kilocalories per 500 milliliters to the total caloric intake. However, research has shown that more efficient metabolism of nutrients occurs when lipids are administered daily to provide a number of kilocalories roughly equivalent to that supplied by glucose. So some agencies are using 500 milliliters of 20% lipids daily, yielding an intake of 1,000 kilocalories. Refinement in the preparation of glucose, amino acids, and lipids used in TPN has enabled lipids to be mixed in a 3-in-1 combination rather than given as a separate or piggyback solution. In addition, electrolytes, minerals, trace elements, and vitamins are normally added to the solution when it is prepared. Sodium, potassium, phosphorus, calcium, and magnesium are added separately, while trace elements and vitamins are usually given in combinations of multivitamins and combined trace element solutions. To review,
The solutions administered for TPN are composed of a mixture of dextrose, amino acids, lipids, and various additives in precise quantities determined by the individual patient's needs.
Careful handling and storage of TPN solutions are necessary to prevent decomposition of additives and bacterial growth. TPN solutions are generally prepared in the pharmacy in order to reduce the risk of infection, particulate contamination, and incompatibilities. Many vitamins, B complex, A, D, K, as well as amino acids are light sensitive and should be protected from light until used. Storing solutions in the refrigerator will protect them from light and will prevent them from decomposing if the temperature is maintained at 4 degrees centigrade, 39.2 degrees Fahrenheit. Even when refrigerated, solutions containing insulin and vitamins are only stable for 24 hours and so must be mixed on a daily basis. Since it is somewhat uncomfortable for a patient to receive a cold infusion, many authorities advise removing the solution from the refrigerator 1 to 2 hours before it is used. Remember, because many of the additives are light sensitive, the bag should be protected from light while waiting for the solution to warm up. Prior to using the solution, the nurse checks the container for leaks and pinhole tears and inspects the solution for floating particles, discoloration, precipitants, or oil floating on top of the mixture. If any of these are present, the solution should not be used. The solution should be labeled with the patient's name, location, formula code, bottle number, solution ingredients, and expiration date.
To review, since some of the components of TPN are unstable, the solution should be refrigerated and protected from light until ready for use, and checked for integrity before using.
TPN solutions are administered by means of an infusion pump in order to maintain accuracy and safety of administration. Although various brands of pumps differ in specific features, all pumps have certain characteristics in common. An on-off switch that controls the power to the pump. An AC battery indicator that indicates whether the power is being supplied by electrical current or battery. Control switches that enable the line to be purged and start the infusion flow. Flow rate and volume switches that allow setting the rate of administration and designation of the total amount to be infused. A display of the flow rate and volume. A pump chamber that holds the administration assembly and provides the drive mechanism to pump the solution. A flow sensor that detects both the number of drops being delivered and the presence of air in the system. An alarm indicator that alerts the user to an occlusion between the pump and the patient, the presence of air in the line, the completion of the infusion, or a low battery. An iMed pump will be used for this demonstration. If your agency or institution uses a different type, become familiar with the special characteristics of that pump. When preparing to administer a TPN solution, the nurse will need to assemble the solution bag, provide iodide swabs, a catheter clamp, 1-inch adhesive tape, sterile gloves, and administration tubing if required. Intravenous nursing standards of practice recommends that administration tubing be changed every 24 hours, while the Center for Disease Control recommends that it be changed every 48 hours. The nurse should, of course, follow agency or institutional policy. To change the set and add a new solution bag, wash and dry your hands thoroughly. Remove the administration tubing from its box and tighten all clamps. Remove the protective cap from the administration spike and from the administration port on the solution bag. Spike the bag through the port, being careful to maintain asepsis. Hang the bag of solution on the IV pole. Squeeze the drip chamber until it is filled almost to the top. And pat the sides to bring any air bubbles to the top of the bag. Turn the power switch to the off position. Adjust the flow clamp to maintain the flow of solution temporarily. Set the rate dial to 000. Turn the power switch to the on position. Press the purge switch until motor shaft is in the neutral position and the bellows are centered. Snap the pump administration tubing cassette into position, making sure it is firmly engaged on both the motor shaft and the bellows. Insert the output tubing into the air detector. Open the flow clamp, then press the purge switch until the cassette, tubing, and connector are free of air bubbles. Set the infusion rate. Set the volume to be infused. Since the patient is at highest risk for an air embolus when in an upright position, lower the patient's bed to a flat position. Remove the tape from the catheter connection site. Don sterile gloves and clean the connection site with 2 povidone iodine swabs. Close the flow clamp on the old tubing. Clamp the venous access catheter with the catheter clamp. Remove the protective cap from the end of the pump administration tubing. While the nurse disconnects the old tubing and connects the pump administration tubing to the catheter, the patient should perform a Valsalva maneuver to increase the pressure on the vena cava and prevent air from entering the catheter. Make certain that the connection is tight, then unclamp the catheter. Press the start button to start the infusion pump. Tape the catheter tubing connection securely. Record the date and time of the tubing change. As well as the date and time the new bag of solution was begun. The administration set is generally changed when a new solution bag is added. If the next bag of solution is added in less than 24 hours, it should not be necessary to change the administration set. Clean the connection site between the set and the completed bag of solution with povidone iodide. Clamp off the tubing and disconnect the set from the bag. Remove the protective cap from the new bag. Spike the bag and hang it as before. Most hospital patients on TPN receive 2,000 to 3,000 milliliters of solution daily. That is 1,000 milliliters every 12 hours or every 8 hours over a 24-hour period. Patients on home parenteral nutrition usually receive their infusions on a cyclic basis at a constant rate over an 8 to 12-hour period, interspersed with a 12 to 16-hour rest period.
The physician's order usually specifies the rate of administration, but if it does not, the nurse must calculate the rate according to the drop rate of the administration system. For the iMed, the drop rate is 20 drops per milliliter. To deliver 1,000 milliliters in 8 hours, the flow rate should be set at 125 milliliters per hour. To deliver 1,000 milliliters in 12 hours, the flow rate would be 83 milliliters per hour. The nurse should check the progress of the infusion periodically to see that the correct volume of infusion is being delivered. The TPN solution is a carefully prepared combination of nutrients which should be infused at a constant rate in order to avoid metabolic complications. No attempt should be made to catch up or slow down an infusion that appears to be running at the wrong rate. If there is any discrepancy, the system should be checked thoroughly to detect any malfunction and the TPN team notified of the problem. In general, pumps monitor the flow rate, the total amount of fluid infused, the status of the battery, and the presence of air in the line. And they are designed to be as trouble-free as possible. But if a problem does occur, all pumps have an alarm system to alert personnel. Most pumps have both an audible alarm and a flashing red light to indicate that a problem has been detected. The nurse should become familiar with the pumps used in his or her agency, so that if an alarm indicates a problem, the nurse will know how to correct it. To review, accuracy in administration, constancy of rate of infusion, and safety of administration are crucial to the success of TPN therapy, so an infusion pump must be used. Generally, the solution is administered under strict aseptic technique at 1,000 milliliters every 12 hours or 1,000 milliliters every 8 hours, or a total of 2,000 to 3,000 milliliters daily. In Part 1, you have seen the uses and indications of hyperalimentation, noted some of the major factors involved in the choice of a venous access device, identified the major components of the TPN solution, seen how solution should be stored and handled, and followed step by step the administration of TPN. The major focus of nursing care in Part 1 is on the proper preparation and delivery of the nutrient solution, and on safe aseptic technique in its administration. Total parenteral nutrition is an effective method of delivering life-saving nourishment. It is the responsibility of the nurse to see that it is administered accurately and safely.